All right. So I think that, as I said at the beginning, tremendous interest in when you go home, when we go home, the patients say, okay, what was the new drug you learned about this year, right? So what I'm going to go through and summarize with you is what my take was, and then you can tell me what your take was, all right? So the abstracts that were this year that I selected, this was, I would say, quite an unusual and unexpected abstract from a new Swiss team that we don't normally see working in our myeloma trials. And they put forward this result using 34 patients resistant to Velcade, and based on some indications that giving, along with the Velcade, an age drug, a protease inhibitor combined with a proteasome inhibitor. Very confusing. But they have preclinical data indicating a synergistic effect, overcoming of the resistance, and the combo was reasonably well tolerated. Questions were asked. It seems that these patients were indeed refractory with a very interesting response rate of 65%. They also showed this cascade plot with some pretty deep responses over there. And so very, very interesting. And maybe we'll just take these new drugs individually. Sagar, so what was your take on this?
Yeah, I mean, so we've actually got a scientist who's been trying to get us to do this for a couple of years at our place.
All right.
And it really all has to do with glucose metabolism within the tumor cell.
Okay.
And that by using the protease inhibitors and or metformin, you can actually significantly alter the Krebs cycle. I mean, that's the simple way to put it, right? I mean, there's a lot of complicated enzymes in there, but you can modulate metabolism within the cell and shut it down, and then when you bring in ER stress from a proteasome inhibitor, they all fall apart. So we've resisted a little bit despite the really, really interesting clinical data. What struck me about this was first the response rate, as you show here.
Yes.
But then when you start to look a little bit more at the details, the median number of cycles that patients got was 4. Now, the max per protocol they could get was 6, and that was a cost issue. But if 2/3 of the patients responded, why didn't 2/3 of the patients get 6 cycles? Right? We were not exactly sure how that worked. And there was a lot of heme toxicity.
Yes.
50% of patients had grade 3, grade 4 thrombocytopenia. Significant number of patients had neutropenia. So these drugs are not benign without their own added toxicities. And I think what the presenter said that actually I completely agree with is we need additional follow-up or we need additional data, meaning another trial, to sort of validate this concept.
Yeah, that's pretty much what I heard. Everyone said, this is really intriguing, but let's do another study to validate and see what's going on here. So,
completely agree. Don't have much more to add apart from the fact that, for a number of years we've had a lot of work in the lab that seems to validate this. And I think that's why it gained a little bit more credibility with me because of what we had seen from a scientific side. But I agree, there's some unanswered questions. Remember, it's not a massive study with lots of patients, but clearly enough signal to test this a bit further because wouldn't it be great if we had a different class of agents here to add to our current growing groups of classes of agents for myeloma?
Yeah,
absolutely. So very interesting, very intriguing, certainly new. Now, venetoclax, the BCL2 inhibitor, exciting data here. This is the single agent, also combination data. We did hear about this a little bit last year, but I think that these are more decisive data this year. Shaji Kumar presented the single agent data, relapse refractory disease, and this is amazing that in the 11-14 subgroup, the patients who have what we could call a favorable BCL2 pattern, so in other words, they are the most susceptible to the inhibitor, the results are still pretty dramatic with a 40% overall response rate with some pretty deep responses in there as well. In discussions, I know actually you commented, I guess you have one of the patients in this trial who's done extremely well. Is that right, Sagar?
We have several that had gone through all available therapies, didn't really have anything left, and when we saw that patient as a consult from quite a distance away, the marrow came back 1114, and we said, and we actually took a sample up to the lab. So Larry Boyes at our place has got that whole profiling that you mentioned for sensitivity. He can do that in a 12-hour assay, and predicted that this patient would be highly sensitive to the drug. She was the second or third most sensitive patient we'd seen, and we'd profiled 50 or 60 patients. She rapidly went into a VGPR and is now MRD negative for close to 2 years now with one drug.
Pretty strong advocate there. What do you think, Joe?
Well, I'm an author on this paper, so I gotta be careful what I say. But you're absolutely right. I mean, I have 2 patients who literally were deciding between hospice and going on to the trial because they had failed carfilzomib, Pom-Dex, one of them, and now been on the study for 2 years. So it seems to me that although it's a little bit of a, if I can call it a boutique area, translocation 1114, which happens in 15-ish% of patients if it's done correctly. For that group of patients, it can be very effective. But as you know, the other study with venetoclax presented with bortezomib was perhaps validating it along with bortezomib in more than just the 1114, because even the non-1114s did better, whereas here in our single agent study, the non-1114s really only had about a 6% response rate, so it was quite minimal. But with the combination with bortezomib, which you have here, that Philippe Moreau presented, I think we saw a much stronger signal. And not a big shock scientifically based on how a proteasome inhibitor works and how this BCL2 inhibitor is working. I think we are not shocked to see this kind of synergy, although maybe the results were a little bit better than we anticipated. So I think this is actually going to be a veritable target drug that we're going to hopefully see available to us in the not so distant future. It's already proven itself in leukemia, in chronic leukemias, it's proving itself in lymphomas. Myeloma might join that fold shortly.
Yeah, I mean, I would take it almost one step further and say we've done a lot of work on deep sequencing and all sorts of molecular profiling of patients in all different settings. This, with FISH, is the closest we've gotten to precision medicine in myeloma.
Right. So Joe, let me ask you this, with that point, what is the approval path for this drug? Is this a drug for the 1114, as you're saying, a precision approach? Do you see that as
well, if you look at just our single agent study, that would have been it. But this study here makes me think that maybe there is a broader net for the drug when combined with bortezomib. I think that perhaps the fastest pathway could be just in 1114, but then it's restricting it to that 15% of patients. This I think validates it in a further context that if they could do a bortezomib venetoclax versus bortezomib study and show that signal to be that strong, then I think they have a path to
so I agree with that, actually. I have to say.
And the other quick point to make about this drug, it's oral. It's quite well tolerated. I mean, every drug comes with, unless it's mother's milk, everything comes with some toxicity and risk, but most of our patients on this study are tolerating it quite well. It doesn't come with a lot of the side effects that we see with other myeloma drugs in terms of neuropathy or significant drop in the blood count. So that's been very encouraging. So in future, I suspect it might be an interesting partner with other agents, not just with bortezomib.
Yeah, very, very good. Yeah, so very promising. And this is certainly exciting stuff to report back to our patients. So for the selinexor, again, this is a drug that's been presented actually for 2 or 3 years now. This is a unique mechanism of action involving the oncogenes and the nucleus. And so we have actually a total of 4 trials presented with selinexor. And so this first one, I don't know where they come up with these acronyms, but the STORM trial is selinexor combined with Dex. 79 patients, and they were looking at the quad and the penta refractory. So these are patients very, very heavily pre-treated. And so my first question to you, Joe, I guess maybe start with this one is 21% response rate, 20 for the penta. So how does this strike you? This
strikes me very strongly. One, we were participants in this trial. I've had a number of my patients go on this. In fact, I think this was a good story of collaboration, working with a company to say to them, the true unmet need in multiple myeloma might not just be people who have seen these drugs, but patients who are actually truly refractory. We had to prove refractoriness to each of these drugs. So, for example, if someone had VRD, a transplant, and then lenalidomide maintenance and progressed, they're not refractory to bortezomib. They're only refractory to lenalidomide. But in that situation, when you're refractory to all of those 4 drugs, and then later on we added the cohort of being refractory to the CD38 monoclonal antibody, where there was daratumumab, some of these were isatuximab, 20% response rate. To me, this was very, very significant. This could well be the next drug available to us in myeloma. And in fact, the fact that it was 20 and 21 between the quad and penta further, I think, validates that it's coming from a unique mechanism. I think the challenge with this drug earlier on that we've overcome mostly was the GI toxicity. In the early days, people really didn't want to eat anything. They had horrible nausea. People were getting weight loss. There's a small subset of patients that have a salt metabolism problem that get really low sodiums. But now that we've sort of aggressively managed that from the start, watch for it and intervene, now the majority of our patients can actually take this agent. And it's a pill, so it's conveniently given. So I really think the fact that it's proven itself on its own to get its own invitation to the party is a big deal. But then it's going to be a natural partner to others as well.
Right, and so just the other thing is that, as I understand it, the side effects seem to be strangely even a little better with the combos.
Right, that's I think so. There are 2 points here. One, we're already seeing the impact of Dera on trial design for new drugs.
Yes, absolutely.
Because they had to create a new category where they were Dera resistant.
Right.
And I think we're going to see that in many, many other new drugs that are coming down the pike as well. The second point, I think, is that, as you mentioned, the anorexia, the lack of appetite, the fatigue, and the nausea really are some of the biggest issues that we saw. The Dex helped a little bit because it was probably more so in the selinexor alone category. But I would actually almost argue from the data we saw at the meeting, combining selinexor with both bortezomib and carfilzomib, that the best antiemetic for selinexor is not Zofran, it's a proteasome inhibitor, because it really did make a lot of those symptoms better.
Absolutely, this is what I was referring to, so that in the combinations we have Velcade, we have pomalidomide and carfilzomib, and exactly, it seems that the toxicity is much less, and the responses are really quite good. And so this is the alternate approval pathway, is what is the next trial coming up, the randomization in the STOMP trial, the Boston trial?
The Boston trial.
Boston trial,
selinexor, bortezomib dex versus bortezomib dex.
Okay, yes. So it sounds to me that you both are looking on this reasonably favorably and be keen to see those results.
Absolutely. Absolutely.
Okay. So actually, this is the last abstract or kind of collection of abstracts that I picked that are being presented or have been mostly presented at ASH this year, the CAR T cells. And so for those not familiar with CAR T cells, these are the patient's own cells which are engineered and directed against the myeloma, picking different CAR targets. And so in this case, the target is CD19, which actually can be present on myeloma, and we can talk a little bit about to what extent it was actually even present in these patients, but giving T cells that are targeted against the myeloma to see if this can wipe out the myeloma. And at this meeting we saw also a BCMA target, a B-cell targeted approach, and then even an antibody approach. And so if we look at those three, you have the CAR T against CD19, against BCMA, or even an antibody. How do these results strike you? We have here, obviously it does not work in every patient. There were 3 long remissions right here. And so there is a lot of, I would say, hype about this. There's a lot of expectation that this can be a really good treatment. Maybe you want to start us off on this. So what do you think about these CAR T cells?
Well, I think I share people's excitement, but I also think it has to be put in the right context. I think as scientists, we get like all hot and bothered about things like CAR T cell therapy, and it's all exciting because we're manipulating T cells and we're directing it back to someone's myeloma. It's under the umbrella of personalized medicine. It's very unique science. It's the kind of thing that makes the cover of the newspaper or Time magazine. And I think it's very exciting because in some other fields, in particular in certain leukemias, where people have no other option, where they're pending death, sadly, I think it's very much validated itself. The reason why I'm a little bit more cautious in myeloma is two things. One, I'm not sure we've come up with the perfect target yet. I'm not sure CD19 is absolutely the ideal target. I think BCMA is moving that direction, and the antibody that you mentioned is maybe even moving a bit more in that direction. But the second thing that concerns me a little bit, Brian, honestly, is this isn't easy therapy. I have patients coming into the clinic saying, oh, I can get CAR T-cell therapy, can't I?
Yes.
This is worse than a transplant. I mean, these patients get really quite sick. We've had some deaths, as you know. The FDA has put some of this work on hold and consideration because of it. I thought today, sitting in one of the abstract sessions, if this were just a novel drug and someone was standing up and saying in the 10 patients they treated, 1 died, 1 went to the ICU, we would all say, wow, we really need to step back. So I think we need to apply the same rules to new drugs as we do to new modalities of treatment like CAR T-cell. So I hope I'm not scaring people. But I do think that we need to be cautious about something that might sound Star Trekian and exciting and wonderful, but can also really hurt people. So I want to be very cautious around this thus far.
Right. So maybe, Sagar, you could put it in perspective. You hear these cautions. So we have the cautions about the therapy itself, and then to kind of put it in perspective with all of the other evolving and novel therapies. So what's your take?
Yeah, I mean, I think, what's really interesting about the CAR T-cell approach is that it has been very much in the news. Everybody's really excited.
Yeah.
It's phenomenal science. And I think the way that things are being done from a delivery of therapy aspect, it is sort of cutting edge. It's as cutting edge as you can get. But I think the real question is, of the people that need this kind of therapy, what fraction can actually get it?
Right.
Not because they can't get to a center, it's how many can actually get the cells delivered to them.
Yes, and also have a transplant potentially.
Correct, right. So I think it's a complicated process, and as scientists, we should remain somewhat methodology agnostic.
Yes.
Meaning that if we have tools to treat our patients, then we want to use them in the best way we can. So if you pick BCMA as a specific target, which I would think from an immunotherapy perspective is probably the best target in myeloma. Okay. It's almost only exclusively expressed on plasma cells. Every other target we've used, including Dera, including ELO, including CD19, is expressed on other less mature B cells. BCMA is almost only on myeloma cells.
Right.
And so we have 3 different ways to attack it. We can do it with a monoclonal antibody that has an antibody drug conjugate. That was presented at this meeting, 60% response rate, single agent.
I know.
We can do it with a bispecific or a BiTE antibody, also a way of engaging the immune system and getting responses.
Right.
Or you can do it with a CAR T-cell.
Right.
Let's see the data in terms of response rate and durability of response, and then make a decision on what's the best way to go.
Absolutely, absolutely. So I think we've kind of covered this here a little bit, and so I'm going to go to what is our last slide, just to kind of think about having been here at ASH and, realizing that we're seeing some old therapies again, some new ones. What was the most important 1 or 2 things that you learned here at ASH this year, or are expecting to learn with this late breaker tomorrow?
One, I would say fewer, if any, second transplants and consolidation therapy. So maintenance lenalidomide is enough.
So big piece of information there.
2, Dera combos are truly validating themselves and coming up earlier. And 3, I'd like to see selinexor and venetoclax get to the clinic sooner than later.
Okay.
Maybe if you wanted a bonus.
Yes.
CAR T-cell is getting close, but I'm still a little bit, and I agree with Sagar as to what he just said, I'm not jumping totally on the CAR T-cell bandwagon. If anything, it's probably a really small bandwagon for a few people that it may very much be helpful for.
Yeah, I mean, I think for me, obviously, I think everything you've described is right on. The ability to finally target and enhance immune function against myeloma is something.
This concept.
We've talked about it in cancer therapy for 40 years, and nothing ever happened.
Right.
Now we finally have the tools to be able to do that. And when you think about, yes, bites, CARs, all that other stuff, but the pembrolizumab data was pretty impressive.
Yes.
Not just the response rate, but the durability. That PFS was 4 times longer than what we saw, actually 5 times longer than what we saw with Pomdex alone.
Right.
So the response rate may not have knocked you off your socks, but certainly the PFS was really quite impressive, and that's the strength of immune
so that
therapy.
True immune modulation is a key aspect. Going back to that MRD and the immune modulation,
Absolutely.
very important to understand it and to enhance it as much as we can.
Agreed.
All right, well, we've covered a lot this evening, and I'm really grateful to you both, especially Sagar for jumping in at the last minute. And so
he makes a pretty good Marie-V.
Yeah. Well, I mean, you got to work on your hair, though. But anyway, so I think that we're really, really pleased that you've joined us this evening, and we really hope that we've given you some exciting new information. We are certainly trying to give you the flavor of what has been going on here in San Diego. So thanks again.
It's a pleasure.
A good evening to everyone, and we will be looking to seeing you again next year. So thank you all.